Okay, welcome everyone, and I hope you enjoy the lunch. The next presentation will be in English. It's the only English presentation for today during this track. And as presenters, I would like to welcome Johan Gustafsson and Kaisa Kujansivu. And thank you. Johan is the CEO and co-founder of the health tech company Visiba. And Kaisa is the Chief Medical Officer and Specialist in General Practice in Pihlajalinna in Finland. I apologize for butchering the name. Okay, welcome.
Thank you.
Thank you. Thank you. Yeah, it's funny with the name actually, because almost all my colleagues, even though we worked with you for many years now, almost no one can pronounce the name Pihlajalinna, which
Yes.
is. But I think I can do it quite well.
Yeah, you do it well.
Reasonably well, at least. I've been practicing a lot. Nice to meet you all. Great that you could be here. So today we'll talk a little bit about what happens when AI starts to unlock time as part of the healthcare system. So obviously Kaisa will do sort of the most interesting stuff, but I have the privilege of opening up and setting the context a little bit, how this fits in a bit to the Swedish system and everything that goes on around here. So last year we did a presentation where, and this is I think the only Swedish slide today, where, because I had a Swedish speaking colleague of Kaisa who was here on the stage last year, and then we talked a bit about what's the potential for Pihlajalinna based on data of the implementation we did in the region of Kronoberg. Which was quite interesting, because some of these numbers actually were something they looked at quite a lot when they looked at the potential. And one of the things we did this implementation at a primary care clinic called Trelleborg, quite successful. I would say Trelleborg is probably the most successful primary care implementation ever done in Sweden using AI-based triage. And one of the things we could see is that in average you freed up 7 minutes per contact with a nurse. That's quite a lot. And we reduced also 61% reduction where actually a patient case needed involvement from a nurse in the contact. And then we tried to see what would happen if that would be expanded across a whole region. So we looked at the whole region of Kronoberg and said, well, what happens if we do that? That would have meant 18,000 fewer patient cases needing to be handled, and it would also mean 267 working days on every month freed up in nurse resources. So that's quite a lot in terms of the pressure that Swedish healthcare is under right now. What I did together with Kaisa's colleague at that point, we looked at the volumes of Pihlajalinna and said, what would happen if Pihlajalinna would broadly implement this across all of their services, which includes occupational healthcare, public primary care, and insurance-based healthcare, which would about 30,000 fewer patient cases, and 444 working days every month in freed up nurse time. So that's quite significant. I know you're not really there yet, but still these are quite interesting numbers. Now, putting like that aside and talking a little bit about what's going on in Sweden at the moment. So at the moment we have some large ongoing initiatives in the Swedish healthcare system, and the biggest one probably the whole sort of integrated care, what we call nära vård in Sweden, is a big project, or probably connected into a lot of different, but it's a common vision of what we're trying to achieve with healthcare. A lot of things are focused around the transition towards integrated care, but there's other projects as well. One of them is the implementation of what is called 1177 Direct, which is a digital way in for patients, which include, or were meant to include, some sort of triage assessment, and from there be able to guide the patient right. You could imagine that when you have such a large initiative around integrated care, that all the other initiatives were supposed to align with that project or go in the same direction. But from what we have seen, that tends not to be the case. They're not fully aligned, and the indications we receive when listening to the outcomes of what is happening is basically that 1177 Direct tends to go in the wrong direction. It does not support the continuity of care. It does not increase efficiency on primary care, especially on a specific primary care clinic level. The only thing you might say is that it could increase accessibility, but probably not for the people that need it the most. I think that's an issue. We have similar things going on in the Finnish market as well. So I wanted to at least sort of introduce that a little bit. So for Pihlajalinna, you have a digital front door for all your services, public health care, occupational health care, insurance care. There is a national digital triage solution. I think it's called Omaolo. But similar to Sweden, it's quite simplistic. It doesn't really accurately be able to triage patients. And I know it's also limited to use within public healthcare. So you basically said, well, we need a locally chosen solution for digital triage to do the work, which is why we started working together with you guys. And obviously, when looking at this, taking it into a region or how this should work, I think there's different levels where you can implement AI-based triage. You could do it at a very central level with when you call in on the phone, or have a national digital entry point, like the digital front door nationally. You could have a regional entry point. You could have out-of-hour services where you could take some of the pressure off primary care at certain out of hours, for example. But the main point here is if you're doing a transition towards integrated care, you need to make sure that the patient's clinic are doing the most work. They're the ones handling a very fragmented inflow of care, including new symptoms, planned revisits, your chronically ill patients, and all the administrative inquiries. I would say hopefully that will give you a little bit of context of what Pihlajalinna does and what's going on in Sweden. And I think bear that in mind when Kaisa is presenting some really interesting numbers of what AI triage could enable. So with that said, I will leave the word to you, Kaisa.
Okay.
Oh, I think I had one slide. Sorry.
You can continue.
My
just
bad.
Yeah.
Yes. So the product that Pihlajalinna has used to implement, just like a short minute on that. So Red Robin and Visiba triage. Visiba triage is our overarching name for what we do within triage. Red Robin is our medical device, the sort of legal name of the medical device. What it does, it basically it automates the medical history assessment. So patients come in, they describe their symptoms, they're being asked automatically a number of questions, and based on these questions, our medical engine and our AI network helps to automatically produce the most likely differential diagnosis and how urgent is it for a patient to be seen. Based on this, we can help healthcare providers, our customers, to configure what is the most suitable profession that this patient should see, and what is the visitation form. So could this continue in a chat? Should this be a video consultation? Does this need to be a face-to-face meeting? And based on that, we can set up these referral groups and automatically refer patients to the correct profession and visitation form. But the healthcare professional also can see a patient summary, and which is basically a decision support for them in taking the next step. So then, now the word is yours.
Thank you. Hello, and a little bit about me. I'm Kaisa Kujansivu, and I'm a
a Chief Medical Officer in Pihlajalinna e-health unit. And I'm a specialist in general practice and also a doctoral researcher in Tampere University, where I'm working on my dissertation on remote consultations. And about Pihlajalinna, Pihlajalinna is one of the largest social and healthcare providers in Finland, with service production models for public healthcare, occupational healthcare, and insurance cooperation. And we have about 40% of visits via the remote channels. And majority of these are performed by the Pihlajalinna e-health unit. We have had Red Robin in Pihlajalinna first in a public healthcare pilot in 2022, and then we've expanded the use of Red Robin in occupational healthcare with primary care patients, and then expanded further on with more occupational healthcare patients and public healthcare services also. So each project has felt like safe enough to expand the tool for the new areas also. Here you can see the basic patient flow we have. The patient contacts the digital clinic and goes through this authentication first, and then proceeds on to the digital triage with Red Robin. And Red Robin asks the medical history and with the questions about the patient's symptoms, and then segments the patients and also defines the urgency for the symptoms. And then the patient proceeds to the online chat with the nurse. And the nurse can see what the segmenting is. Is it self-care instructions, maybe referral to emergency or these urgent appointments, and then scheduling face-to-face appointments for professionals, and also referrals to remote physicians. And at this point, the Red Robin is able to refer the patient straight on to these online bookings with professionals, and also straight on to the remote physician. We have had approximately these 50,000 sessions of AI triage over the period of 7 months. And what is remarkable here maybe is that first we started with about 800 triages per month, and then we've had up to 7,000 or even 11,000 triages per month here. The users have been mainly Finnish native speakers, women, and working age. So this is also due to the fact that we use it with occupational healthcare patients.
So Kaisa, just a question on the last slide there, because you went up from 800 per month up to 11,000. How did you sort of make sure that everyone came through that pathway? Because that tends to be a challenge to get the volume up in these sort of implementations.
This is like expanding the use of the tool for like new patients and new areas. So they just we need a good campaign for all the patients that they need know where to contact us. And it's there's the app or the web page where they can contact us through this. But there are also other channels, so they can still contact us by phone and so on. Here you can see the digital triages, the 50,000 in total, and the Red Robin segmenting. And what's remarkable here is that the Red Robin suggests up to almost 20% of the patients for self-care instructions. And then up to 60 or 70% of the patients we can it can refer past the gatekeeper nurse to proceed on to these online bookings for face-to-face appointments or the remote physician. And this is not meant to be used with these like acute symptoms and emergency cases, but if it turns out that the patient has acute symptoms, it recommends the patient to call the emergency number, and still if the patient continues with the questions, and everybody gets contacted with the nurse in the end also. So no one is left without contact or care. And Red Robin also here segments the urgency. Is it like 1 to 3 days or maybe over 3 days here? And over 90% of the patients that come in with this channel completed the digital triage in 3.5 minutes. And within this 3.5 minutes, the Red Robin asks an average of 19 questions of the patient medical history and then on the symptoms.
Yeah, it's quite. If you look at that, the conversion rate, it's quite interesting that so many are able to complete the full chat. Comparing that to other services, I would say that's a quite high number. Or what is your experience?
Yeah, almost everyone finishes it when they start it, so it seems to be easy enough to and quick enough to finish the questions. And here, based on the 10,000 feedback loops from these 50,000 triages, the clinicians picked one of the suggestions in 95% of the cases, what the AI suggested. And this has stayed on for 95 to 97% during all these months. So it's been quite accurate. And Red Robin always, it just only the suggestion, it doesn't make the diagnosis by itself. So the clinician makes the decision.
Yeah. When you look at like you say 95 to 97%, it seems like a very high number. Would you say that the clinicians themselves would agree more with each other than 95 to 97% or less?
I would say they would agree with each other less than with Red Robin maybe.
Yeah, that's quite interesting.
Yeah. We also had this clinical panel in the first pilot, where we had specialists evaluating independently these 50 cases of Red Robin referrals, and in most of these cases, at least one of the clinicians agreed with Red Robin, and most of these yellow ones that they did not agree were due to these different sick leave practices in Finland and in Sweden, where Red Robin was not trained yet for the Finnish practices here. And we also noticed that when we proceed on to further and further cases, we disagreed with each other more and with Red Robin more. So it might be due to the fact that people lose focus doing this kind of work quite quickly, and the machine does not lose focus. It always functions the same. So experiences from Pihlajalinna, Red Robin has been piloted in occupational healthcare with primary care visits and public healthcare, and the feedback from professionals has been positive. And also customer feedback has been quite positive after 1 month of learning period of contacts. And all of these patients were referred to a nurse, and so this segmenting hasn't been in full practice yet. We've seen that duration of the nurse chat was reduced from 30 to 50% from the situation where the Red Robin was not used in chat. And at least in theory, we could refer 70% of the patient past this gatekeeper nurse here.
And that number I think is quite interesting. So what you say is that when you're looking at the accuracy of Red Robin, 70% could be referred past the nurse, so no nurse would actually need to be able to look at it. But at this stage, you have not implemented that. What is the reason for that?
It's mainly the healthcare system that we have guidelines that we cannot leave the patient for example, with just self-care instructions, and also these occupational healthcare contracts are different, so we need to contact the patients personally, but it's basically mostly because of that also.
Yeah, some really untapped potential for sure.
Yeah. What we think are the benefits for digital triage is the greater efficiency for the professionals and shortening of the chat by this tool, and with information on patient medical history and evaluation of the symptoms, and we could do automation of routine work with systemized and standardized patient interview. And the digital triage is also constantly developing. The AI-induced tool has a new version with every 3 weeks here.
Yeah, I think when talking about the last part, because I know our clinical team works really hard, and our AI engineers work really hard on improving the accuracy of Red Robin all the time. But how have you experienced that in any way?
The difference is so small that in practice it's really not that noticeable that it gets better. So the difference is...
Yeah, so like from 95 to
Yeah.
95.3, it's small.
Yeah, you can't really see it in practice, yeah.
Yeah, in the large volumes, I completely understand.
Yeah. What are the potential risks for digital triage, and what do we think about this? Is what if the patient is left without treatment, or what if the patient cannot manage with digital devices? The patient safety is priority here, and the patients are always directed to professionals. And we have this continuous quality control and referral follow-up and system updates. And the patient can always have in-person contact if they want to. So they can call us or come by and so on.
Right. We have like a minute left, but there's some like summary or main points here. So what you talked about, Kaisa, is you piloted this now and had a lot of positive experiences. And what do you feel is sort of like, obviously this creates a lot of value, but what's the next step for you at Pihlajalinna?
Probably is with the occupational healthcare primary care patients, we could already let them book the appointments according to Red Robin, segmenting to different professionals, and continue to remote physicians straight on. We could do that already.
Yeah, interesting. I don't know if we have time for any. Daniel, you're like
time
moderating
for questions
here.
here. Are there any questions from the audience?
I have a question. Thank you for your presentation, both of you. My question would be, how did you ensure the buy-in by clinicians? You know, the usage results are really impressive. How did you achieve that they trust triage system?
Well, I think when the professionals see that it makes their job easier, and they always have the contact with the patient, and they can have their own questions, and they can see themselves that the suggestions are quite accurate. So by the work, when they also see it, it makes it easier for them. It's also increases the trust with the system. Yeah.
So you have some regular follow-ups and monitoring of the adherence and so on.
And they also like with every contact they give feedback with it, how did it went and was it accurate and so on.
Wonderful. Thank you. There's one question.
Hi, I was wondering if you have had problems with legal hurdles. If I understood it correctly, it seems like you kind of regenerate this triage process every 3 weeks through AI, and feels like that would raise like a lot of red flags for legal hurdles if you kind of regenerate a model. Is that anything you experience having trouble with?
Well, because the tool doesn't like make the decisions in itself. It only makes the suggestion, and then the professional makes the decision, and always has the conversation with the patient. So we don't see a big problem with this.
And I could also add that we are in the final phase of achieving our CE mark according MDR at class 2A. We are under the MDD at the moment, but soon under MDR. So we're following all the process around that. So obviously, once starting the certification, you can't do major changes to the product, but you can do sort of minor improvements. And I would say the continuous improvement of the medical content and the questions are a part of the minor improvements continuously being made.
Thank you.
Okay, thank you.
Thank you.
Johan and Kaisa.
Thank you.